Welcome to all of you for this webinar, and thank you to be with us this evening. Before starting, I would like to present you Dr. Sandro Valle. He's a specialist in anesthesiology, consultant, and he comes from Germany. He will present us some practical strategy that improve patient safety through structure, processes, checklist, and team training. I also would like to thank our historical partner PAJUNK for the organization of this webinar, and Jeremy, of course, for his assistance. I would also like to remind you that if you have any question, you can use Q&A button instead of the chat room. And I remind you also that it is a recorded session. Let's start this nice webinar.
Good evening to you all. Hopefully you can hear me. Thank you for the warm introduction and the warm welcome. I'm starting my presentation right now. If I can't hear anything from you, I think you can see everything. So yeah, thank you for the warm introduction. My name is Dr. Sandro Valle. I'm an anesthesiologist from Germany. I'm proud member of the ESRA for many years now. And I really looking forward to spend the next 45 to 50 minutes with, I can say that, with my favorite topic, and I'm pretty sure it's your favorite topic too. So my topic today will be patient safety Standard 2.0. The title is Risky Regional, Not on My Watch. And as you can see on my title slide I made with ChatGPT, for me, regional anesthesia is a superhero. So I will present you some ideas. And let me start with disclosure. I don't have to disclose anything that takes influence on this topic. I receive some paid honoraria from PAJUNK for lectures and education activities, but nothing does have any influence on this presentation. So what is my topic? Patient safety doesn't start with the needle. It starts with structures and processes. So we all know that patient safety does have to do with preventable errors. We all heard about for many years now about human factors, about the importance of standardization. So my main goal of tonight will be, I want to tell you our story in my hospital and our hospital about some practical ideas for safer processes and optimization. So it will be a very practical presentation. I will not talk about any complications in detail, I'm sorry. So you will not hear about the pros and cons of regional anesthesia, perform it before or after general anesthesia, because it's a matter of time today, and I think there's a lot of discussion about this topic. We will not talk about ultrasound in detail, and I'm going to be very frank with you. I will not present you with evidence for every idea you can hear tonight. So it will be a very practical presentation about ideas how to improve patient safety. And I want to start with a little poll. So you can think of two questions. Let us think, hear your answer after the session. So write it down, think of it. So the first question is, do you have in your institution, wherever you are, any standardized operational procedures, any standards? Do you have any checklists for your procedures? Do you have a plan A or plan B for worst case scenario? And of course, do you always have enough time, enough equipment for the regional anesthesia you would like to perform? That's the first question. And the second question is, if you think of one safety measure of your choice, and I put it at the beginning of this presentation. If you think of just one measure, which would you like to choose? What kind of measure you think is most lacking in your institution? I'm really looking forward to your answers. Think of those two questions, and let's discuss it afterwards. So, and another thing I want to remind you, everything you hear tonight, take it with a hint of salt, because there's always a lot of ways to get to the goal. So if you ask, for example, ChatGPT to do a picture of ancient Rome, what will it produce? It will put an ancient Rome with a bus. So nothing is perfect. There's a lot of ways to do regional anesthesia, and I'm sure that I'm presenting some good ideas, but there's a lot more to this topic. So what is safety in regional anesthesia? Why is it a key factor? So let me make sure that we don't strive for a 0% complication rate. That is not our primary goal. There's not the tool to guarantee patient safety. It's a combination of a lot of things. But in my opinion, if you perform or think of regional anesthesia as a crucial part of a perfect patient care, like our colleagues in surgery do, I think we should perform it more like an art. And I think regional anesthesia should get out the shadow of its big brother anesthesia. It's a separate, valuable field, and we should perform regional anesthesia always under perfect circumstances. I know it's not always possible, but we should strive for the maximum effort for success. And in my opinion, we should do it for the patient's satisfaction. And if the patient is happy, most of the times we are, but not always. For example, we could do a block and the patient is happy, but we were not happy with the technique. So this is a topic to avoid and to make sure that something is safe. We should be happy about it. And the last thing is we should do regional anesthesia in a way to make it medical legally sound and solid. So this contributes to safety in a lot of ways. This is maybe the only slide you see about a complication, because we know that in regional anesthesia, complications are more or less well understood. We have read a lot of papers about nerve damaging. Maybe you have a standard about nerve damaging. We all know, and we argue every time with maybe our surgical colleagues about this, that the complication in regional anesthesia is in general very low. It will never be 0%. That is not our goal. And we agree that a lot of complications in regional anesthesia can be potentially life-changing if we think about neuraxial damage. And we can agree that it is often preventable. But I can remind you that we should always be careful with hindsight bias. What is hindsight bias? If a damage happened, like in this case, I will just talk briefly, we all know it better when it happened. So, but when we are in the middle of performing a block and something happens, nobody does it on purpose. Like in this case from 2012, where, for example, a healthy 20-year-old male received an interscalene block, and you see in red highlighted the things I think were more or less problematic. So they did a classical catheter technique, and they threaded the catheter 7 centimeters beyond the needle tip. They used a lot of local anesthetic, like 40 ml bupivacaine, and it was performed without ultrasound technique. And this young man died. He was found dead in his bed because the catheter entered, the dura mater and had a high spinal anesthesia as an effect, and he was found dead in his bed. So it's maybe, I'm pretty sure, totally preventable, but be careful with hindsight bias. So we want to talk about how to prevent those things and what strategies there are. So I'm very happy that my beloved and very colleague Markus Huppertz-Thyssen, who had a lot of webinars on YouTube, for example, talked about the interscalene approach. And you see on the left side that it is a fantastic block, with any doubt, but it's one with high incidence of complications. And he recommends a paper from Barry Nichols. I can recommend too. I put the QR code of this webinar so you can listen to it again. He talked about best practices for safety and quality. And if you want to read more about interscalene blocks or the strategy of Barry Nichols, I only suggest do it. You will find a lot of evidence there, a lot of tips and tricks. My topic today will have 3 parts, and I call them the 3 pillars of patient safety. The first pillar is education and training. The second one is process and checklists. And the third one is culture and teamwork. And I think that only if you manage to to build 3 solid pillars that patient safety is at its maximum. So what can happen if you don't think of patient safety? I present you a few cases that happened to me. So the first one is an own case I had years ago. It was probably 2017. It was an elective total knee replacement on a male patient. It was not regular daytime. It was the same hospital I'm working now. It was optimal circumstances. I put in a question mark. It was me as a doctor and a highly experienced anesthesia nurse. We wanted to perform at that time a femoral anesthetic block, and we asked the patient which leg it was. And what happened? We performed the block on the wrong side. And the remarkable on this case is that nobody complained, not me, not the nurse, and not even the patient. He thanked us for our good work, and he was fully awake. So we didn't have any checklist at the time. It was just daily business. It was daytime, so there were no stress factors in this sense. But we all know that is not the whole story. So you find in the article from Barry Nichols a lot of reasons why we perform wrong-sided peripheral nerve blocks. I won't talk about every one of those points because they're self-explanatory. But you can see it here. A lot of times it's, of course, stress. It's human factors. There's not a surgical mark on the leg. It was a factor at this time too. There's a time factor. So there's a lot of things you can think about that stresses you. So it happens, and patient safety depends on you, because if you are the one performing a regional anesthesia and you perform it on the wrong leg, the patient, and most of the times, there's a good chance he won't complain. So the first pillar is training and education. Make sure that you use the best procedures and techniques for your patients and your department. Do regular briefings, teachings, and practice. And adapt a case-based learning. Why anatomy is important. So just don't teach the block. Make sure that your colleagues and your residents and everyone, your nurses, know why you're blocking this nerve and not the other one. So in this evening, we will not go through, of course, every block there is, but I will start with 2 sentences that impressed me a lot, very much. I had the pleasure to participate in a lot of ESRA workshops, and one of them was in Innsbruck, and Professor Morrigal, some of you will know him, and he has the famous quote, "How do we know if it is a nerve? Because it looks like a nerve." So it sounds funny, but at the end, it's a very wise sentence, because if you recognize a nerve, that's the first step for patient safety. And Barry Nichols once said to me in another ESRA, I think it was in Lugano 2017, you only see what you know. If you don't know what you see on the screen, you cannot perform a safe block, because you will not know where your needle is. So I can start with some practical tips and tricks, what we changed in our hospital. So, and maybe there's something for you. So we don't perform any interscalene blocks anymore. At least we try. We introduced new blocks in our standardized operational procedure. So we try to use only the superior trunk block. You find with the QR code a good webinar I did some months ago. It is in German though, but maybe you can translate it in YouTube. I am convinced that the superior trunk blocks contributes to more patient safety. It is more distally. It has less risk of phrenic pulses. So think what techniques are safer, because they will have the same goal. And we heard about the danger of interscalene blocks. So think about new techniques. We use less volume. In my institution, we strive for 1 to 3 mils for a single shot. That's not always possible. I'm fully aware of it, but we never inject more than 5 to 10. So those times with 40 ml of lidocaine or bupivacaine, I think they should be over. And it's very good, very well backed up by evidence. So, and we drastically simplified, and we are continuing to simplify our equipment. I will talk to you at the end of the presentation about this, to a very few good needles. We are trying to switch to a one-size-fits-all needles. Before 2023, we had at least 6 different needles. We had 3 different catheter sets. We had 3 different sizes in single shot needles, different length. And I think that's dangerous because you tend to not use the equipment you're familiar with. And when you get a needle you're not familiar with, it can cause a lot of damage. And one thing is, we don't use classical threaded catheters anymore. We had, I think it was 2021 or 2022, a very case of catheter rupturing. It was another manufacturer, so we switched the manufacturer, and we switched completely last year, 2 years ago, to a catheter over needle system. We used the eCatheter 2 Plus with a 1.5 centimeter extra tip. You can see it here. And I'm fully being honest with you, this is one of the few equipment changes. I think it's revolutionary. It changed completely our daily practice. Since then, we didn't have any catheter rupturing, no leakage. Before that, our hand surgeon complained about catheter leakage in the axillary fossa, and it's practically over now. We have a more precise tip location, and it's way faster and easier. I wouldn't say you can't do any errors. You always can do something wrong. But you can see on this ultrasound image on the right bottom, it's very well visible on the ultrasound. And there's very few errors you can do it. You just inject, you put it on the right spot, you insert the catheter, and your work is done. So in my opinion, it's just my personal opinion, we don't use any classical threaded catheters, and this contributes a lot to patient safety. You can see here about 2 years ago, I think, the evidence how you can improve your interscalene block: use less volume. Less volume means less complications. It is backed up by evidence. You have less hemidiaphragmatic paresis. You will never have zero, not even with superior trunk block, but it's going down to a percentage you can live with. What did we change besides that? We don't perform region anesthesia without any ultrasound. I know that ultrasound is not a miracle tool. I'll present some evidence for you that surprised me too. And we always aim for dual guidance. And let me be clear, I don't use the nerve stimulator so much for nerve identification in every block, but for only for safety. You all are aware about the milliampere threshold and so on. So use it. Use this device you have. And I can advise you, just try to use as much as possible a color Doppler. And one of the most important changes we introduced in 2024, every change I'm talking to you in this presentation was introduced in my hospital in 2024. So it is possible. We use less blocks, but I call them better blocks. We use less blocks with less nerve damaging risks. We use motor sparing blocks, so-called fast track blocks. I give you an example. We don't use femoral fascial or sciatic blocks, let me say, for routine knee arthroplasty or hip arthroplasty. Of course, for accidents, trauma, and patient with great pain and some indications, you always can use whatever block you like. But for the routine daily basis, we switch to a femoral triangle block and a pain block. For those who are not familiar with this, you can see on the left side, hopefully you can see the video, the blockage of the nerve to vastus medialis, which is, in my opinion, contributes to more patient safety and more pain quality. And you have to use an ultrasound, of course, for that, and you have to use a nerve stimulator because you want to stimulate the nerve in order to not damage him, and of course a little bit for nerve identification. If you don't use a nerve stimulator, there's a great risk you just puncturing this nerve on the way to the adductor canal, and the patient is in risk to have an atrophy of the muscle, and this has to do with patient safety. So it's the same way Dr. Hacic talks about using a nerve stimulator for pain blocks. So we introduced the nerve stimulator for every pain block because the femoral nerve at some point and sometimes is in the way of the needle. You don't see him always with a curved probe. So if you see a quadriceps stimulation, you know there's the femoral nerve in the vicinity. So these are two examples how you can perform fast track blocks with less motor, with more motor sparing potential, but you have to use a nerve stimulator. So we use less blocks on our arthroplasty patient. And I think this contributes a lot to patient safety. Less nerves means less risk of nerve damage. And I was very surprised about the ultrasound evidence because I was aware until now that there is not a lot of evidence to back up the ultrasound use for nerve protection. And take it with with a little bit of hint of salt. I performed the first time in my life a deep research analysis with ChatGPT. It took about 10 minutes. And ChatGPT analyzed more than 4,000 patients and 47 randomized control trials. And I checked every one of them. And on these 4 trials I present here on the left, it has as a result that ultrasound had an increased block success rate, a higher success rate, and reduced the complication rate. So maybe it's the first time we see that that's not entirely true, that ultrasound is not backed up by evidence. So for me, it is a good news, but I'm fully aware that even with ultrasound, you can do and harm the patient. But if we are not using ultrasound, I think it will be even worse. So the first or the second case I'll present to you, the first part of the second case, is that in my opinion, fast track blocks make sense. What happened? We did a couple of months ago an elective total knee arthroplasty. He received a femoral triangle block with dual guidance, like we always use. And then after this block, so he was fully awake, his final anesthesia, which I will talk later. The complete procedure was totally uneventful, but at the evening, he had foot drop with hyperesthesia and numbness on his foot. What kind of diagnostics do you think we should perform? This is think of it, the answer, and maybe we'll see if you were right, if there's a right answer on the second part. But think of this question right at this moment. How would things have turned out if we had performed a classical sciatic block as we used to do 2 years before? So if he had sciatic block and at the evening he had foot drop with hyperesthesia and numbness, would you have done anything? So think of the answer. I will come back to it later. And I promised you I wouldn't talk about general anesthesia versus regional anesthesia, but this is the only slide you will see from me in this topic. I'm fully convinced that the avoidance of general anesthesia in a lot of cases, not in every case, does make a lot of sense. So here's here a case of a total shoulder arthroplasty. This is our OR. It was a 90-year-old lady with history of confusion. She had recent pneumonia. She had a more or less recent stroke. She had always states of confusion. So she received a supraclavicular plexus block and some skin nerves. And she received this total shoulder arthroplasty without any sedation, without any opioids. It took 2 hours. So she was thirsty. We gave her something to drink during the middle of the procedure. You can see the procedure in the middle of the screen. And she went directly to the ward. And I was very happy to check on her on the same day. And the next day, she was she went home at the, I think, 3rd day without any confusion. That doesn't mean it has to go this way every time, but I think it made a difference. So, and this contributes to patient safety a lot. What did we change in education techniques? There were changes to be made in spinal anesthesia. So I'm aware that you probably will perform a lot of spinal cases. We switched I repeat, everything we did, every change you hear, we changed it in 2024 or 2023, the end of 2023. We switched our local from bupivacaine to prilocaine. We use an individual pre-packed spinal set now that increased our safety because we don't have to use and look for every equipment separately. And we try, at least I do, and a lot of colleagues do, we try to routinely use and implement the ultrasound for spinal anesthesia. You can see here 2 live images from patients, and that on the right side, that's me on, I think it was a hip arthroplasty. I'm performing the local anesthetic and introduce a needle on live scanning, and then I put the probe away, and we mark the height, and this contributes a lot to patient safety. So I can only advise use ultrasound for your spinals. This is definitely backed up by evidence. So that you see here 2 papers, and I will present another slide. And it's backed up by evidence that it minimizes technical difficulties. You need fewer needle puncturing. You have lower risk of bleeding. You have an excellent correlation between the depth and the needle insertion depth. I have to be honest, it's not in 100% of the cases. So we perform a lot of ultrasound spinals nowadays. So maybe this year I did about 20 to 30 cases. And I think in about 10 to 20%, you still have a difficult spinal and you contact bone and you have to correct your needle angulation. But it helps you a lot with difficult cases, and I think there's a lot of evidence supporting a beneficial role. And my colleague talked about this in the webinar I showed you before, and these are just a small choice of positive evidence about the role of ultrasound in neuraxial anesthesia, and the answer is probably it is very helpful. So try to implement it for your patients and try to use it in every healthy patient, because that's the only way, in my opinion, to gain some experience. So the summary of techniques and equipment, just to a small examples, is always use ultrasound. This is my story. Always use dual guidance with color Doppler if it is available to you. Always decide if in plane or out of plane will be of benefit for the patient. That's the thing I mentioned about satisfaction. You have to be happy, but the patient has to be happy too. Think about your techniques. Start tomorrow and think, is there a better technique I can do for my knee or hip patients? Do you really need to block every nerve or every anatomical region? This contributes to patient safety if you maybe can block less nerves and still have the same result. Use as little as volume you can. Avoid multi-puncturing the patient, and this can only work if you plan your blocks properly. And this is my opinion. I don't want to advocate for products, but I'm very happy with our catheter over needle system, and I'm very happy that we introduced the catheter over needle system and don't use the threaded catheters anymore, because we don't have this problem about how much do we have to advance the catheter tip. It's over. From one day to the another, it's over, and you don't have this problem anymore. The second part of my topic is checklists. It sounds annoying, it sounds boring, but it isn't. Think of what elements should a good checklist include, and I give you some practical examples. So we introduced SOPs that help. I think at least that's a tip and you can do that help people. It should be easily available online, and we wrote SUP with step-by-step direction. You can see it here for every block. So residents, colleagues can click on the block they want to read about, and they have our standard about how to block this. Documentation is key, and you have to have a SOP. And we decided in our department, if people want to write in a certain way the documentation, they can. If they use the technique like in the SOP, they can refer to it as stated in SUP. That unifies the techniques and eliminates the need for question in difficult cases. So if you have a patient damaging or nerve damage, the resident or the colleague can say, I used it as quoted in the SOP. And this gives the responsibility, of course, to us, to my boss, to those who wrote the SOP, but it is everything state of the art, from books, from daily practice, from evidence. So we don't write anything that is not backed up by standard practice. We introduce standardized prep tables for everyone. So here you see an example for the nurses. They know exactly what to prepare. If they, of course, I'm sorry, it is in German, but I think you get the idea. Even with little pictures, so they can see all the materials they have to prepare, and what kind of needles they have to prepare, and there's explanation step by step. So this improves medical legal issues, it improves them, and it increases the safety. So, and my advice is make visual aids visible to everyone and everywhere. So we made big posters and attached it on every wall. So on our block room, I will talk about it in a couple of minutes. And this is not my idea. This is made by Nisora and RA UK. We just changed it to our needs. We translated it in German, and we included only the blocks that we need. We did some live real pictures. This is all our own ultrasound imaging. And we so people can look at the block posters when they're not sure what to do before they perform something. They can just stand before it. This is, by the way, our PACU with a great view on the lake. And I think this increases patient safety a lot, because if you are sure what to do and you don't hesitate to use visual aids, it only can be beneficial for the patient. So, and we are very strict on this. So we made another poster. This is the room we used to do the pre-op assessment with patients. So we have anatomy explanation poster. So when we explain everything, risks and benefits of the blocks and the anesthesia to the patients, we can indicate with our finger, for example, where to perform the block. And patients can see that we take this issue seriously, and they can get a feeling of what happens, what area will get numb. They will not be afraid if the foot is going to be numb afterwards. If you just explain it with gestures and in theory, I think patient will never get the consent and informational value you can have with anatomy poster. So my advice is show them where and what to block and what area will be affected. This increases visibility of regional anesthesia, and this makes regional anesthesia safer and more valuable. Make checklists. So this is one of the biggest topics today. We have introduced 2 checklists, one before regional anesthesia and one afterwards. So the first one is the well-known stop before you block checklist, and the other one is the last checklist. These lists already exist out there. It's not our invention. We changed it to our institutional logo, and we adapted some things we don't have. We eliminated some other things we don't use. So adapt them and use them. So the stop before you block checklist, thank you again, RA UK. We use them before a needle insertion. We do a brief team time out with the doctor and the nurse. So it's just 2 people. We talk about the materials, the technique, and the equipment involved. We check allergies. We ask the patient for consent. If he cannot consent, we check the paperwork. And of course, we check for the correct side. Maybe that's because of my experience, and I'm so happy that we have this checklist. I'm honest with you. Sometimes it slips out of my mind too, and every time it does, I'm angry to myself, but I think in 95% of the cases we use the checklist before inserting the needle. It's just 10 seconds. You talk about two or three topics, and then you're ready to go. You can see the original publication. It's a beautiful YouTube video. I suggest do it, scan the QR code. If you don't do it now, this presentation will be online, and I think in a couple of days, and you can Google it. So there's nothing new to it, but my advice is just use a stop before you block checklist. We printed this out and attached it again to the wall, and we take it seriously. You see one of our ultrasound machines, and we printed it in plastic, and so you can disinfect it. It says in German, did you disinfect the probe heads? Did you disinfect your hands? And use the stop for block. So I'm hopefully that everyone, before using having patient contact, is respecting those 3 safety measures. The other checklist you see below, it's the last checklist. It's used when you have, in rare cases, a catastrophic event. It gives you a step-by-step approach what to do in case of toxicity. Again, this is not my invention. I saw it on ESRA in last year. So thank you, Dr. McFarlane. We introduced the tox box in the PAJUNK. In this tox box is a lipid emulsion. There's this algorithm for catastrophic event. And we did something. We inserted the phone numbers for extracorporeal life support and extracorporeal membrane oxygenation, because we don't have that in our institution, but we have a hospital nearby. I think it's 30 minutes away. But you need the phone numbers. So if you really, in rare cases, have to do CPR on this patient, there's a high chance that you have to do a long CPR. And I can tell you, if you are in this situation, nobody will remember the phone number. So we included it on this checklist. And this was the original picture I took on ESRA last year. So thank you for this tip. And we introduced it in our department too. So I can only give you the advice, use a checklist for catastrophic events. This is for patient safety. So this was the second part about checklists and SOP. The summary was use standardized OPs that are visible to everyone, print everything out, put it on the wall, limit it, of course, to 2 or 3 things, have a plan before block and have a plan after the blocks. And the last topic is communication, organization, and teamwork. This is a real difficult thing because if you don't take regional anesthesia seriously, in the sense of if it's only just a technique to you, you will never be aware of complications. So you have to highlight the importance of regional anesthesia and the visibility to everyone, to surgeons, to the ward, to intensive care, even to those who think that regional anesthesia is just a fly-by technique. You have to introduce a safety culture. So one of my goals is to move from the old-fashioned who is to blame when the block failed to how can we prevent this together, and more to an anatomy-based approach. So for example, if a patient with a total knee arthroplasty still has pain in the PAJUNK, we switch, at least we try to switch from a culture of, oh, you did the block wrong, to a culture of, oh, maybe I didn't manage to block every nerve that is involved. How can we prevent this? Let's do a better block, or let's do the block now. And I think we got a lot of success. And in our heads, we changed it from doing better blocks. And I'm happy to hear your comments on this. And we maximize the optimal circumstances for regional anesthesia. And I'll show you some practical examples. So we created a block room. This is, I have to be honest, one of the biggest changes in my career. And it's the first time I see this. my boss, our head of department, transformed the old PACU, you can see here, which was very small, didn't have any windows. We limited it to 4 fully monitored bed spaces, and we do all the preparations of the patients in this room. So we have the regional anesthesia equipment. We have, of course, backup ventilation, all emergency support you need. All the patients are called in time. We have a structured check-in handover. We start the vitals, the IV needle, and every block in most of the cases. And it's the first time we have more time. In most of the cases, it's less noisy for everyone because there are no surgeons, no OR nurses, no other people, it's just the patient and anesthesia personnel. You can see here the same posters, the same checklist, the same equipment. We have 3 spaces where to put the paperwork so we don't get the patients confused, we don't confound the patients with each other. And this is backed up by evidence. Again, Markus Huppertz-Thyssen gave the evidence that if you create a block room, you have more time efficiency, faster turnovers, shorter inductions in emergence times, and shorter length of stay in the recovery room. And if that is not patient safety, I don't know what is. So we have less stress, and this contributes to, for example, the errors I did performing the block on the wrong side. But this is not, the journey doesn't stop here. So safety starts with small steps as long as we start. So we do regular faculty meetings. Every Thursday, we have an educational session. And I think every second Thursday, we have regional anesthesia topics, sometimes 3 in a row, sometimes 2 in a month. We have a digital folder where we put every PowerPoint and educational material inside, available to everyone. And last year, we started fast-track surgery on arthroplasty patient. We have every 2 weeks a patient information event where patients from outside that want to have surgery come and get the information. And why do I tell this to you? Our anesthesia department is a crucial part of it. We speak to the patient about regional anesthesia, what happens to them. We give them a brief overview of the techniques, what can happen, what are the benefits, and we make clear that there is no surgery without regional anesthesia. In most of the cases, of course. If the patient doesn't consent, that's another thing. But I never experienced the patient doesn't consent to a block. So make yourself visible, because this contributes to safety if the patient is informed. And one of the biggest changes we introduced this year, and it's one of my favorites, is Welcome to the Club. We introduced the Spinal Anesthesia Awareness, I call them Club wristband. And again, it's not my invention. I don't want the credit. It's an invention by Dr. Rachel Mathers from England. She published it in Regional Anesthesia and Pain Medicine 2 years ago in ESRA. Here you find the QR code of the original publication. And I thought of the idea, so it was such a great idea that we introduced it in our hospital. So what is this? Every patient with the successful spinal gets it. It's a bright yellow paper band. It's a medical paper band. We printed our own hospital logo on it. We take the time of a successful spinal anesthesia, for example, 8 o'clock. We add 4 hours. It's just a random time frame. You can, of course, use 5 hours if you like, but 4 hours is more or less. Don't forget we use Prilocaine. And this is the calculated time for the leg raise test. This time is noted on the wristband together with instructions. You can see here on a real, this was our first patient. And at this time or earlier, the patient can check himself if he or she can straight lift the legs from the bed. So if successful, he or she rips the wristband off. If it's not successful, maybe he waits a little longer, or the nurses call the anesthesia. What are the goals? It creates an awareness for spinals that last too long. We had 2 cases of bupivacaine spinals 2 years ago that lasted 8 hours. Unfortunately, those ladies were in the same room. And what happened? Nobody called us. The nurses called us the next day because the ladies had a lot of questions and they complained. So in this case, it creates an awareness for potentially devastating neuraxial complications that are rare. I'm fully aware that they are rare, but they are devastating. It creates an algorithm for nurses when and who to call. It gives physiotherapy a visual aid because we do fast track, so we mobilize our patients the same day, and sometimes the physiotherapy gets in the room and wants to mobilize patient, and they see on the wristband that the spinal, maybe it's another 2 hours, the patient cannot lift his leg, and maybe they decide to come back at the time that is noted on the wristband or later. It reduces insecurity with the patient. It assures and motivates patient. And the last point is that, at least that's my hope, it gives patient a kind of club feeling. You can see here, that's my first video I created with AI. And I think maybe that's a goal we can achieve, that patients that opt for spinal, they feel that they're in a special kind of club with this kind of wristband. And please note that the color of the wristband is not by chance yellow. I come to this back in a couple of moments. So this is our SOP about that. We designed it for nurses and for the intranet. So nurses can check if the patient has a yellow wristband. They test it at the time noted. And if it's successful, they rip it off. And if it's not successful, they call anesthesia. And it's well published that it created awareness in the same year it was introduced. We even integrated in our team timeout sign-in in the ORs. This is the WHO team timeout list we use in the OR. And we introduced a line that is going to be printed out this month. So when we do the team timeout, we talk about the time noted on the wristband. So this is the original idea by Dr. Rachel Mathers, and it's absolutely easy to implement. A wristband costs about 11 cents. So this is an example of our first patients, 3 hours after the wristband. You can see, hopefully you can see the video, and after 3 hours, he can freely lift the leg, the other one too. So we took the wristband out. To consider, the time noted is not a permission to ambulate. Please be aware, it's not a permission to ambulate. It's just to prevent and to be aware of potential complications. And I'll give you a first experience. We received a call a couple of weeks that the patient could lift at the time noted on the wristband. He could only lift one leg, but not the operated leg. What would you do? So what happened? We were informed. And in my opinion, this is a success because one of my colleagues checked on the patient. And at the end, 2 hours later, he could lift both legs. So maybe it was just a delayed effect of the surgery, or maybe he had some pain in his hip, I don't know, but he checked on the patient. And this is everything I wanted to achieve, is to create an awareness. And you can see here on our medical record software, it's so cute to see that nurses are starting to implement it on their daily kind of talking. So I'll translate it to you from German. So in the green circle, you can see my documentation that I performed the spinal at 10 o'clock. And what the nurses wrote is that patient returned, he was awake, no nausea, and his legs are now fully mobile in bed, and we removed the yellow wristband. They don't have to document this in theory, but they do. A lot of them do it because they want to create some medical, legal documentation, and that's great to hear that they introduced it into their daily practice. So this is the second part of my case. Remember, it was a gentleman who received a femoral triangle block and a spinal anesthesia. So this was his anesthesia technique. And his wristband said 5 p.m. After the spinal wore off, he had this already mentioned foot drop with hyperesthesia and numbness. And it was 1 hour, I think, after the wristband was taken off. And he had foot drop with hyperesthesia and numbness on his operated foot. We did the next day a neurology consultation with MRI, and he had a damage to his common peroneal nerve. And by coincidence, he had spinal canal stenosis, but no prolapse. So the wristband was taken off 1 hour before the problem emerged because he lifted the legs without any problem. So in my opinion, the wristband was clearly a step for faster diagnosis because we were sure the same day that there was at least no dramatic problem with his spinal canal, and this was a surgical problem. I'm fully aware that you don't do MRIs maybe the same day or the next day, but the wristband helped us to be faster and to rule out that it was maybe something to do with the spinal. So what are challenges and solutions to some problems? All of that I talked about is not so easy to implement, but you will have at some point some resistance by your own team, by other colleagues, by some other faculties. Fortunately, in my institution, it was really smooth to implement. But this is one of the problems you have to think about. How to sell those new safety measures effectively. They cost money, a little bit at least, and they cost time. How to integrate your time of training for all those workflows in your daily routine. So I can give you another idea. We introduced, I think it was 1 year ago, 2 years ago, the freelancer anesthetist. We call it it's a German abbreviation for central coordination operator, whatever you call it. We don't have a specific name. It's an anesthesia consultant or specialist. He's very experienced, and he's not planned for a specific OR that day. He takes over the anesthesia, for example, in the OR number 1, and the colleague from OR number 1 steps outside and performs the regional anesthesia in the block room. So we make sure that in this way, we make sure that everyone who wants to be trained can have a constant training and has constant opportunities for practicing. So this is one solution maybe to this problem. And one of the main things I'm so happy to talk about, it's just brief. We are finally switching to ENERFit. For those of you who are not aware what this is, it is mandatory and, in my opinion, not negotiable. It's a norm. It's an ISO norm by the WHO in 2007. And in Germany, in Europe, it's mandatory in theory since 2016. And we are switching in July with the help of the company of PAJUNK. And starting from July, the classical syringes and adapter will not work anymore with regional anesthesia equipment. Everything will be yellow. And this is why I chose yellow as the color of choice for the wristband. I chose a really bright yellow, so everyone is aware regional anesthesia and yellow is a match. So I can only advise, do the switch as soon as you can, because I think ENERFit is one of the biggest changes and contributions for safety. And again, this is backed up by evidence. There were so many errors, preventable errors, by connecting a central line to a catheter line, by connecting an epidural to a central catheter line. And this is not excusable. If this happens nowadays, every lawyer, every court will tell you, why didn't you switch to ENERFit? So the equipment is there. There's no excuse, in my opinion. So I think 20% of the hospitals are using ENERFit. It's still too low. And I think in UK, it's mandatory. We reached the timeline already. It's mandatory since January. So again, we are a little they are ahead of us. But I think I'm so happy that we're switching, and this is a major game changing. To close my presentation today, we still have a lot of open ongoing projects. We still don't have a pain nurse. I want to be part of the national safety network here in Germany for quality management and long-term analysis. We still don't have an objective measurement tool of patient satisfaction. For example, we check every patient individually. We don't have an objective analysis tool in our hospital, because we do a lot of paperwork still. We're not very digital in our anesthesia documentation. I know that, for example, we raised our spinal quota from 10% to about 40% in 1 year, but this is just more or less an analysis made by the nurses. I'm happy to participate in June to the advanced patient safety course from DESAIC, and there will be a masterclass of this, how to learn more about patient safety. So this is another goal. Use all the educational possibilities that are out there. I didn't talk about hygienic and hygiene issues. We introduced a lot of hygiene changes last year, 2 years ago. I didn't talk about it because there will be a publication in Germany about a new guideline. And so I didn't talk about it because it can change in the next couple of months. And we still didn't implement any pressure monitoring. So I'm aware that it is not 100% backed up by evidence, but it's another step for patient safety. So let me close my presentation with one of the last slides. I can give you the advice: stick to every great idea you find. For example, this probe cover used by Dr. Hacic in New York, it impressed me a lot. Unfortunately, it's not available in Germany, and I think it's genius. So if you have the chance to use ideas from other people, ask them for permission and use every idea you have, because the patient will benefit from it. So let me close my topic with the 3 summaries. Patient safety is a process, not a product. It focuses on processes and not just experience, because even the most experienced practitioner can make errors. Use checklist, SOP, and training as key components, and be aware that everyone contributes to safety, not just the anesthetist. It's a team effort, from the nurses to the assistants to the ward nurses, and so on. If one of them is not willing to contribute to safety, the patient will not have the benefit he could have. So you thought about the first 2 poll questions. Now you think about the last one. Which safety measure will you most likely establish in your institution? Maybe it's one of the ideas you heard in my presentation. Maybe it's something we hear about in the next minutes, because I'm absolutely sure you tell me your ideas, and you can be absolutely sure I will copy them if they are good for us, of course, with your permission. And please let me know your ideas. So let me close with a view from our hospital. This is the view from our patient rooms, and one of the rare cases of a helicopter and a water rescue department days. So thank you very much that I had the possibility to speak about regional anesthesia, and I'm looking forward to hear your ideas. I will stop sharing my screen now. Thank you.
Okay, Sandro, it was brilliant. Brilliant presentation. Thank you very much.
Thank you very much.
13 questions that we can answer all. We start from the first one. If you can open also the Q&A button.
Let me
so you
see.
see how
the first one. Okay.
which
Should I read it, or do you want to read it?
No, go, read it, you.
So it's asked about the settings for the nerve stimulation. We have a routine to not go below 0.5 milliamperes, and we routinely use 0.1 milliseconds and 1 hertz. So it's the absolute standard for every daily patient. And of course, diabetics, difficult patients, we can change those values, but I can only give you the advice: don't use this nerve stimulation so much for nerve identification, but just for safety. You have to know what you see on your ultrasound. If you don't know what you see, the nerve stimulator will not help you.
Good.
The second one is, would you prefer ankle block multi-injection technique to a popliteal block for foot surgeries? Very good question. That absolutely highlights that the thing I told you before. You have to choose the technique that you think is best in your department to increase the safety. If we do sciatic blocks with catheter for our foot patients because they are very complex foot surgeries. For the not so complex foot surgeries, we use single shots. And our surgeon does sometimes ankle blocks by himself, which I cannot control what he does without ultrasound. I love ankle blocks, but I prefer a popliteal block because it's just one injection and I know what I'm doing. But there's nothing wrong about an ankle block if you have good results. Of course, you can have less motor block and less devastating nerve damaging. So there's not a real answering to this question. It's as long as you know what you're doing and not multi-puncturing the patient 20 times for the same result, and at the end ending up with general anesthesia. I think both of them are really good. The third question is, what's the best way to fix the catheter over needle, especially you have a very superficial nerve like the interscalene? Well, this is not a commercial, but this is my professional answer. We use the Fixocath provided by the company. It's a special. At the beginning, it's a little fiddly. You have to get used to it. And let me tell you, it sticks to the skin like hell. Even after 3 days, you cannot peel it off easily. So we use the cushion, the catheter fixation provided by the company, where the catheter is bent onto this cushion. And since then, we did not have, at least as I'm aware of, any leakage anymore, any dislocation. Of course, you can have a bad result if you put the catheter at the wrong spot. But speaking of the fixation, we use the provided tool by the company. When you don't have it, I would suggest putting some small bandage you use for example, performing the IV, and then come from both sides and use transparent adhesive. So we use them for superior trunk blocks, for axillary blocks, for adductor canal blocks, for sciatic blocks. For every catheter, we use this Fixocath adhesive. The next question focuses on anticoagulation. Guidelines on low dose fondaparinate that can receive a spinal shot attempt. Is it a safe approach? Yes, it's a good question. Due to time issues, I will not go into details. We wrote on our standards available to everyone. It took me weeks of work. I can tell you that. I consulted the German national guideline and the ESRA guideline and the American guideline on how to deal with anticoagulation. And we wrote for every anticoagulant available in our country safe time frames. So every resident, every colleague can check on this document. For example, 48 hours on, I don't know, rivaroxaban, or 24 hours, and so on. So I don't know, to be honest, by memory, every drug. So for the 5 most frequent drugs, for the 10 most frequent drugs, we use it in our guidelines, but we don't have a poster. Because I think this is something that is going to be ruled out before the spinal and when you talk to the patients. But you're perfectly right. You have to check at some point when you're not sure. And I can only give you the advice, do it in your department, check your drugs, and establish a time you are happy with. The next question is, involving the patient in the preoperative phase may also reduce the risk of getting the wrong side. Absolutely, there's nothing to add. This is one of the benefits doing it on a wake patient, but even if you're doing it on a sleep patient in a general anesthesia, it is possible. There's no evidence of more nerve damaging when you're doing it in general anesthesia. That's the true answer. Sometimes you have patients that are frightened or kids. Every child in German gets regional anesthesia after general anesthesia. And you have to have a tool to avoid getting the wrong side. But you're right. This is one of the key components involving the patient. And we ask every patient, is it the right side? And give you another advice. At least I do it. I ask the patient, which leg are we going to have surgery today? And the patient says, for example, the right one. And I'm still not, that's not enough for me. I always ask, is this the right one, the right side for you? I take my hand, put it on his right leg, and ask him, is this the right side? Some patients look at me, what do you mean? But I'm being really serious. I tell them, I know that this may sound strange, but some patients confuse left to right. Elderly people, there are people that switch left and right. And I ask the patients, I put the hand on the right side, and is this the correct side? And if both of the answers are yes, I'll start my procedure after the stop for block. Would you advocate to use short-acting mepivacaine over long-acting ropivacaine? Well, this is matter of choice. We use for every block except the emergency department ropivacaine 0.5%. I'm not aware of any evidence that one of the other is safer. But of course, if you feel more comfortable using 2 local anesthetics, you can do it. I am being honest to you, this wouldn't be my choice, because then you don't know which local anesthetic is responsible for which effect and how long you have to wait. So we perform the single shot with ropivacaine, insert a catheter, and start the pump. And that's it. So this is, again, one of the goal, you have to simplify. The more complex you perform your regional anesthesia in your department, the more errors you can have. If you have 10 different needles with 10 different local anesthetics, it's going to be difficult. So we eliminated, for example, bupivacaine and mepivacaine for the daily practice. We just have ropivacaine. And we could use lidocaine for the skin infiltration if you want to. For spinals, we have prilocaine. And so we have 2 local anesthetics for 2 different blocks, the neuraxial blocks and the peripheral blocks. But of course, there's a lot of ways to roam. The next question is, in routine work on anesthesia, my question, how long have been NPO fasting under regional anesthesia, especially nerve block? I don't know if I'm getting it right, how long you have to fast for regional anesthesia. Well, for regional anesthesia, you don't have to fast at all. This is for surgery, you have to fast. If I perform, or maybe now I get your question, you mean if we don't perform general anesthesia? Well, at the moment, we have a 2 hours drinking limit. And in Germany, unfortunately, 6-hour eating limit. It will be changed in a hospital maybe in the future. If patient is fully awake, for example, the elderly people, I give them to drink during the surgery. I'm being honest to you. If they don't have sedation or they're fully awake, and they are thirsty, I get a glass of water, a straw, and they drink. But this is my responsibility. If you don't feel fine, don't do it, because if there's any problem, check your national guidelines. So I can not give you a fully perfect answer to this. How would you deal with a complication? Oh, that's a very good question. Immediate or delayed debrief with the team. We have for this too, SOP. I wrote about 8 pages. This is all in according to the national and international guidelines. I mean, at the end, everything is out there. The ASRA, the ESRA, the national societies, they all have guidelines for nerve damaging. And I introduced everything in our hospital guideline. I changed something here and there because we don't have some diagnostic tools in Germany, and this health system is different. So we have an algorithm, for example, to be called, to document it, we do a fully anamnesis, a fully body check, we do a full a paperwork check, we do a consultation, we write everything down, and of course you have to differentiate between a nerve damage and a spinal damage. So I cannot give you a perfect answer, but the only thing I want is to be immediately called by the surgeons and the nurses if they think that the patient has a regional anesthesia associated damage, which in a lot of cases it is not. And then I debrief it, of course, with our head of department, with the colleagues, etc. But that depends on the case you have in daily practice. For example, with the foot drop, our daily anesthetist was called, the on-call anesthetist, and he gave the information to us the next day in the morning rounds, and then we check on the patient again together. About the regional anesthesia post and checklist, is there any PDF? Well, it has our hospital logo on it, but maybe PAJUNK can provide you the official blog posters by RI UK. You can use them as a model, and then you do your own poster. I only give you the advice, use own material for your own institution. Does the wristband add any medical legal value? Well, we introduced it this year. So fortunately, we didn't have any neuraxial damage at all in the last years, but I'm deeply convinced that it adds medical legal value, because if we can prove that the patient received a wristband, and if we can prove that the patient ripped off the wristband at the noted time, we can prove that we did everything to avoid damaging as in the early period, and that we were aware of the patient. So if he still has nerve damage, at least we can say, well, we did everything, even that. How do you cover a probe while giving a block? At the moment, we use a sterile adhesive. With the hand, we grip the probe, and then we cover it. Next question is, kudos for your team effort to prove patient safety. Thank you very much. Which safety measure is most lacking in your institution? If I may return the question, most lacking in my institution. So you ask us at the moment, NR Fit. So I'm waiting for it anxiously. So hopefully we will have it in July. And the other thing, I would like to have a digital documentation. We don't document any ultrasound image at this point. So we just perform the block and write what we saw. I would like to save every image to a patient file in his medical record software, but it's not possible at the moment. The next question is a lot of questions.
Yes, Sandro, you can answer other 2 questions.
Yeah.
Use the question. And after, I just remember to all of you that the recording of this webinar will be made available on PAJUNK YouTube, and maybe they can...
Okay, yeah, because it's a lot of questions. So I choose another 2 questions. Let me just check. Yeah, this I already answered is volume. I answered is. Let me see. Yeah, maybe this one. Regional blocks in cases with pre-existing nerve injury. It's a good question. A lot of the times the surgeon will say, please no regional anesthesia because the patient has sciatic damage. And to be honest, I will not perform a regional anesthesia in this case. Because there is no value to my own satisfaction and to the patient's satisfaction if we go forward and convince the patient at any cost that he has to have a regional anesthesia. So if there's really a pre-existing nerve injury, but it has to be a nerve injury. I usually don't accept if patient, for example, says he has back pain because of spinal canal stenosis, and he doesn't want any, I don't know, he doesn't want any sciatic blocks because he had a prolapse 10 years ago. This is not a nerve injury. But of course, you have to do it from case to case. And the other one is, let me see. What is your experience with very low dose superior trunk block with analgesia duration? When do you use catheter instead of single shot block? Yeah, we do use catheters for shoulder replacement and for difficult cases when people have to be opioid free, elderly patients that will not be happy with a lot of opioids or have a lot of allergies, or patient with big operation surgeries, then we use catheters. And you have to differentiate between a awake patient and a patient with general anesthesia. So I always use 1 to 5 ml for superior trunk single shot, and then I insert the catheter over needle system, and that's it. And then usually he gets a general. When you use an awake patients, I prefer the supraclavicular plexus block, where I use 10 to 15 ml. So the question is not so much in what kind of surgery, but more in the kind of block you use if you decide if the patient has to be awake or gets general. But the analgesia duration, I don't have any experience that it's longer or shorter. And the evidence says if you use more local anesthetic, it just does more complication, but it does not prolong the analgesia duration. I cannot hear you. Beatrice, I cannot, your mic, you're muted.
Voila. Thank you very much, Sandro, for this. You receive a lot of compliments in the chat. Brilliant presentation.
Thank
you. Thank you very much. It was very interesting, and patient safety always come first. So you were. Thank you very much to all of you.
Thank you very much.
This evening, and you will find this presentation on the PAJUNK account in 2 days, maybe in 1 day, 2 days. Thank you very much.
Thank you very much. Have a nice evening. Bye-bye. Thank you.